Imagine a 16-year-old client who reveals active suicidal ideation, but begs you not to tell their parents. Their guardian, however, refuses mental health care and threatens legal action if the minor is hospitalized. What would you do? The ethical conflict arises between honoring the adolescent's confidentiality and ensuring that they're safe, ensuring their safety. I mean, that's the whole reason that we're doing this in the first place. However, many states, mature minors may consent to mental health care without parental involvement. When the parent refuses treatment, options such as hospitalization or medication, the clinician faces a dilemma: risk breaking trust with your client, or fail in the duty to protect. This situation arises a lot, and it requires careful adherence to the ACA Code of Ethics and state laws, along with team consultation. The point when you run into something like that is to not do it alone, not internalize it. You have to have a team behind you, and the ethics code will guide us in what we have to do, because at the end of the day, we can't change the outcome we can't change every outcome. You can't change other people, but we can try to help them and keep them safe. To navigate the ethical conflict of a suicidal minor refusing parental disclosure, it's critical to apply an established decision-making model. The ACA outlines a 7-step progress that starts with identifying the dilemma, reviewing applicable ethics codes and laws, consulting colleagues, and exploring all options. Hirsch et al., 2020. In this case, we would prioritize the client's safety while working to preserve therapeutic rapport. Consultation with a supervisor and the entire team is essential. That's a must. As soon as that happens, you can't trap yourself in that situation with your client. You need your team at that point, and then we need these code of ethics. Timely documentation that supports ethical accountability and justifies decisions if challenged. When possible, clinicians should help the minor understand why parental involvement may be necessary and prepare for that conversation together, including the caregiver as a partner rather than an obstacle. That's not always possible. We can't control, if we have a minor client, we can't control their home life. And sometimes, as bad as it is, the parents are really the source of the suicidal ideation. So this is why we have to stick with the ethics code, and we have to follow it implicitly, because there's only so much that we as a person can do. In situations involving informed consent, suicidal ideation, and minors, no single clinician should bear the full ethical burden. A multidisciplinary team, MDT, offers diverse perspectives, which helps ensure that decisions are not made in isolation or based on an individual's bias. For example, a social worker, this is part of the team, a social worker, they're going to perhaps they may look at cultural values. A medical provider can assess physical safety risks. And a supervisor is going to help ensure that your agency's policy and the ADA Code of Ethics are followed. The documentation is what's going to keep us from having to be liable for anything. So by building consensus, this helps the team ensure legal and ethical accountability while supporting the primary clinician through obviously difficult moments and decisions. Managing ethical dilemmas, especially those involving minors and suicidal ideation, can take a significant toll on mental health professionals. We get involved, we're in this for a reason, and we're in this because a lot of times, most of the time, we had things happen to us, and now we want to help other people we want to be part of someone else's healing as part of ours. And these cases often trigger moral distress, particularly when we have to override the minor's wishes for safety reasons, like tell a parent that the minor doesn't want to know. And without proper support, this stress can lead to compassion fatigue and clinical errors. That's McKay et al., 2022. That's why supervision and peer consultation aren't just helpful, they're essential, and they provide a space to process complex emotions, complex decisions, your own biases, and everything else. We need a team just as much as our clients do. Emotional regulation, mindfulness, and intentional self-care all improve quality of ethical decisions, reducing reactivity. And that's Gabor Mate, 2003. It's an old book, but I think he nails a lot of it in there. And so I wanted to include that as well as the more updated references here. If we ignore our own wellness, though, we risk becoming impaired. That's when we start wanting to violating ethical concerns, and when we keep this all to ourselves and internalize it. And so we need self-care, which is essential. When working with suicidal minors, the legal and ethical lines can blur fast. Legally, we're often mandated to break confidentiality to protect the child from imminent harm. But ethically, we also have the duty to maintain the therapeutic alliance and honor the minor's autonomy as much as we can. The tension between these duties can be emotionally and professionally taxing. It's everything that we've been saying is to say that when you are involved with a client who's a minor that's suicidal, even if you know the parents may be the cause of the situation, or maybe we understand why our client doesn't want the parents to know, that's when we have to follow the ethical guidelines, because we're not physically capable of being with them at all times to stop a potential suicide. We need a team, and we need everybody to know, including the parents, and that oftentimes, or could be anyway, something that the parents maybe wake up and take seriously. So that's why it's important to consult a supervisor and the code of ethics. So, okay, high stakes care management. This is what we're talking about, burnout. That's why we need this team. To prevent burnout, we need to take our own time off. Self-care is critical. The ACA code of ethics actually emphasizes our duty to monitor and maintain personal well-being. Burnout in crisis settings often shows up as emotional exhaustion, cynicism, and decreased empathy. When we're overwhelmed, we're more likely to make poor ethical decisions, miss red flags, or lose client trust. And that's why I prioritize, small self-care practices that we can do on our own. Cognitive behavioral therapy like exercise, meditation, meditative reflection, right? Connection to friends, a good support system, and, use your systemic networks that are in place. Our supervisors have been there before us and can guide us on those things. Self-care is not selfish, it's protective, and for us and our clients. And, we tell our clients to create wellness routines, and sometimes we have a hard time taking our own advice, like mechanics don't like working on their own cars. Sometimes therapists, psychologists, psychiatrists, we don't like working on our own mental health. It's easier for us to deal with someone else's demons than our own. But if we want to do this as a profession and we want to heal other people, we have to prevent burnout. So, and that's not a luxury, it's a professional responsibility that sustains ethical, compassionate care in the long term. We do nobody any good if we're not at our best.